Wonderful. So welcome again, everyone. Thank you for joining us for today's presentation of the 2021 Community Health Needs Assessment. Today's session is being recorded again for future viewing. My name is Jessica Reeker. I'm the Director of Community Health and Outreach here at Good Shepherd Healthcare System. Our Community Health Needs Assessment is being brought to us by a partnership between Good Shepherd and St. Anthony Hospital. Presenting our findings today are two representatives from Professional Research Consultants, or PRC. We have Bruce Lockwood, Senior Vice President, Community Health, and Jana DiStefano, Director of Community Health. Welcome, Bruce and Jana. Feel free to take it over.
All right. Thank you, Jessica. Good afternoon, everyone. I guess it's officially afternoon now. Glad that you could join us. This is going to be really kind of the first sharing of this information that really just wrapped up at the end of the year. I wanted to hop on camera to say hi, but I'm going to close that out to give you the most real estate for for my slides here today, and hopefully you can all see those on screen. So what I want to do today is walk through an overview of what we learned through this process of the Community Health Needs Assessment that was just completed in December, and give you some of the highlights of the findings that we found. So I'm going to move through a lot of data today pretty quickly. I know we are limited on time. So I want to share with you that what I'm going to talk about today is really just a fraction of all of the information that we collected that's available in the full Community Health Needs Assessment report that's available online, which is a very lengthy document with a lot of data. I'm going to focus primarily on some of the needs that emerged. So really some areas where there are challenges to improve. But I want to point out that there were many positive findings from the assessment as well that I won't be talking about. And we'll have time for some Q&A, I'm hoping, and feel free to ask questions. If it's a point of clarification, perhaps address those as we go through. Something that might be a lengthier question, I will have some time at the end to go through those. It's probably a good idea as we go through, if you're not speaking, if you could go ahead and mute yourself just so there's no background noise, but I certainly want you to be able to speak up if you need. So I want to start out talking a little bit about how we did this assessment, what the process was. So we pulled in information from a variety of different sources. We looked at certainly existing data that's out there, what we call secondary data. That's typically county level information that's available through things like the census or through the public health data sets. So I'll weave some of that information in as we go through today. We also did an online survey geared specifically to what we call key informants. And these are community stakeholders, providers, social service representatives, community leaders of various organizations in the community, to get some very qualitative feedback from them about the experiences and needs, specifically of the populations that they serve. So we do have kind of the provider side available through this key informant survey. Now for today, I'm really just going to have one slide that summarizes some of the top line findings from the key informant survey. What I'm going to include throughout much of this survey, the presentation today, though, is information from what was probably the cornerstone of this assessment, which was a very customized local health survey of residents themselves. And this was a quantitative survey administered to a random sample of residents throughout Umatilla and Morrow counties, geared to understand their specific health status, experiences, behaviors. And this was a survey that was conducted both over the phone, landline, and cell phone contacts. And there was also an internet-based component as well. And let me talk a little bit more about that survey of the population. In all, through all of those various mechanisms we employed, we received 129 completed surveys across Umatilla and Morrow counties. In the map you can see on screen, for the survey findings, I'll be looking at divisions based on these zip code groupings, which roughly equate to the Hermiston area in orange, the Pendleton area in purple. Those were our primary divisions. The sample size for this was really a very robust sample, gives us a very good maximum confidence interval of plus or minus 3.5% at the 95% confidence level. We had good participation, even though the survey is quite long. It was over 120 questions, and for those that administered on the phone, it was probably about 25 to 30 minutes to complete the survey. So we were able to capture really a lot of information, useful information about the population. The last thing I want to point out about the population survey, and this is what's really critical to understanding the sampling and how we can project these to the larger population. Without getting into too much detail, this chart shows the breakouts of different demographic groups in Umatilla and Morrow counties. In orange, those are the portions we see through the latest census data. In red, the same proportions for those population segments in our final survey sample. So the takeaway is that the survey sample very much looks like the population of the community in terms of gender and age and race, ethnicity makeup, even income level. And that's what allows us to say this is a representative sample. So before I get into kind of the bulk of my presentation, I wanted to share one slide of information that we heard from key informants that took that separate key informant survey. Most of that survey was asking them very open-ended questions to explain where they saw health needs in the community. And all of that information is outlined in our CHNA report. But at the outset of that survey, we had a series of health issues that we posed to key informants and asked them to rate each of these as either a major problem, moderate problem, minor problem, or not a problem in Umatilla and Morrow counties. And from that, we can establish essentially a rank ordering of the health issues that they were most concerned about. So again, this is from the provider side of things, where they saw the biggest needs in the county related to clearly mental health, in terms of over 80% reporting that as a major problem. They were also significantly concerned about COVID, about substance abuse, about 2/3 rated that as a major problem. And then 4 and 5 out of a list of about 17 health issues were tobacco use and diabetes. So I wanted to start out with this so you can kind of keep in mind these perceptions of key informants as we go through and I share some of the information we collected through the population survey, as well as through some of the existing data sets. So this slide represents kind of a roadmap of where I'm going to go today. And I know this looks like a lot, and it is, but I'm going to have 1 to 3 slides for each of these broader categories to share with you some of the top findings we heard from our assessment. And I'm going to go through these alphabetically. At the end, I'll share with you kind of the prioritization that came out of this assessment process. But initially, I want to start out with the A's, with access to health services. So in our survey of the population, we had a series of questions designed to identify what insurance coverage, if any, people have for their health care. And for this slide, and this slide only, I'm excluding the 65 plus population who qualifies for Medicare coverage. So this indicator looks specifically at adults age 18 to 64. And we found that 9.5% of residents of the 2 counties has no health insurance coverage whatsoever, either through private health insurance, something through an employer or a spouse's employer or self-purchase plan, or through government-sponsored programs like Medicaid or Medicare, or even military benefits. So 9.5% without any type of coverage whatsoever. And we can look at this in a couple different ways. We can compare it, as you see on screen, to the same set of questions asked in a statewide survey by the CDC, as well as in a national survey that PRC conducts. So we have benchmarking to the state of Oregon and to the US as a whole. And you can see here what I've marked is where we saw a statistically significant difference, and that's from the state level reporting. The Umatilla-Morrow County population actually fares a little bit better than the state overall in terms of uninsured level for this population, but it's closer to what we see nationally. Another way that we can look at the data from the survey is to break it out by certain segments of our local population, for example, by gender and age and income level and race, ethnicity. And what we found is that this isn't equally distributed, as you might imagine. And we found that men, adults in lower income households, as well as communities of color, much more likely to be uninsured. And for reference, as we go through these charts, this low income category includes households with incomes up to 200% of the federal poverty level, which equates to about $52,000 for a family of four. So it's not necessarily just the poorest of the poor. It encompasses a lot of families in the two-county area. Now, beyond health insurance coverage, we know that there are other factors that can impact a person's ability to access healthcare. And we had questions in our population survey specifically to address 7 of those potential barriers, which I'm now showing on the screen. And what we found is in Umatilla and Morrow counties, the barriers that impacted the greatest percentages of populations were those on the left side of this chart. And let me talk about those and what these percentages actually mean. So for example, we found through our survey that 28.1% of adults, of all adults in the two-county area, reported a time in the past year when they needed medical care, but they didn't get it because they couldn't get an appointment when they needed it. 19.4% went without needed medical care because they had trouble finding a doctor to see them. 19% didn't go to a medical appointment that they felt they needed because they couldn't get there during office hours. And you can see by the comparison there that each of those prevalence levels is significantly higher than what we see across the US as a whole. Now, we were more similar to the US for barriers of cost related to physician visits as well as prescriptions, transportation, also closer to what we see nationally. Language and cultural barriers tended to be less of an impact locally than we see nationwide. And I'll mention that the survey was available in both English and Spanish. From the secondary data that we looked at, I wanted to present this indicator. So this is existing data that's out there from the Health Resources and Services Administration, HRSA. And this looks at primary care doctors practicing in the two counties as active physicians as a ratio to the population size. And I'll share with you, there's a few caveats to this particular data point, but by this measure, you can see that the ratio of physicians to population is somewhat less favorable for the local area than it is for the state or the US as a whole. Now, the caveats here are that this data from HRSA are several years old. They aren't very updated, so it was from 2017. The other caveat is that this does not take into account any primary care that's delivered by advanced practice providers. It really only looks at MDs and DOs providing primary care in the 2-county areas. Now, some of the other findings related to this that we had in our survey of the population. For example, we found that a little over 60% of adults report having a physician visit in the past year. That's lower in the Hermiston area than we saw in Pendleton. It's also significantly below what we see nationally, where it's closer to 70%. We also saw that residents of the 2 counties are more likely than Americans overall to have had multiple emergency room visits in the past year. One last question I wanted to share with you in this first issue relates to perceptions of local healthcare. And as part of our survey of residents, we asked them to rate the healthcare services available to them in their community. And it was taken on a scale of excellent, very good, good, fair, or poor. And by and large, most gave excellent, very good, or good ratings of healthcare. On the lower end, though, we saw 22% of adults rate local healthcare as fair or poor. And that's higher than we typically see. Across the US as a whole, it's about 8% fair or poor. Younger adults tend to be a little more critical than older adults. But really the difference lies in whether people feel that they have access. And you can see in this little call out box that I've included. The difference in response between two portions of our survey sample. Those who say they've had problems accessing healthcare in the past year are much more likely to be critical and rate healthcare services as fair or poor than those who did not experience difficulties accessing care. The next group of health issues I want to talk about are a collection of chronic conditions that together make up some of the leading causes of death in the 2-county area. And certainly as part of our assessment, one of the secondary data sources we looked to was the public health data sets, and specifically mortality data, information that's collected through death certificates. And we looked specifically at what we call age-adjusted mortality rates. And these are deaths per 100,000 population, and they're adjusted to account for the age of our population so that we're not biasing any comparison to benchmarks because we are an older or a younger population. So taking that age into account, these represent some of the comparisons of mortality rates for some of the top leading causes of death. Certainly cancer is the leading cause of death, just ahead of heart disease. And those two really make up a near majority of deaths in the 2 counties. And you can see that we're very close to what we see statewide and nationally in terms of cancer mortality. And actually our heart disease mortality is similar to the state and actually much better than what we see nationwide. Some of the other comparisons that I've marked here are ones where we are really statistically higher than either state and or national data. And that includes chronic lower respiratory disease, which includes things like emphysema and chronic bronchitis. Alzheimer's disease, that mortality is higher than we see nationally at least. And diabetes deaths. And I'll talk about a few of these a little more in the coming slides. Now, the one in the middle, unintentional injuries, and while overall that is somewhat similar to what we see nationally and statewide, if we drill down specifically to motor vehicle crash deaths, that rate is relatively high in Umatilla and Morrow compared to the state and the US. We addressed some of these conditions in our survey of the population as well. For example, we asked about gender and age-appropriate cancer screenings to see whether people were getting the preventative services they need. So looking at rates of breast cancer screening, cervical cancer screening, colorectal cancer screening, you can see the Umatilla-Maro prevalence levels in red compared to Oregon and the US. And certainly for mammography and for colorectal cancer screening, we are really very close to what we see statewide and nationally. For pap smear testing for cervical cancer in women aged 21 to 65, our rates are a little on the low side compared to state and national data. And looking back at some of the previous assessments, it looks like those have declined slightly in recent years, at least in Umatilla County as well. In terms of cardiovascular risk, we see a relatively high percentage of adults who say they've been told they have high blood cholesterol on the right side of the screen, 39.8%, higher than we see nationally. Nearly as many, 36.7%, say they've been told they have high blood pressure. And that is higher than we see statewide, but closer to what we see nationally. I also wanted to share some prevalence levels from our survey data around diabetes. So through the course of the survey of the population, we asked people if they've ever been diagnosed by a health professional as having diabetes. And for the adult population in Umatilla, Maro counties, that prevalence is 13.5%. Again, close to what we see nationally, but significantly above the latest finding for the state of Oregon. In terms of demographic, we found what we really find in every community, and that this is primarily age dependent. Prevalence of diabetes rises sharply with age, and for the 65 plus population in Umatilla and Maro counties, it's really close to 1 out of 4 of those 65 plus who've had a diagnosis of diabetes. We did also ask people in our survey if they've ever been told they have pre-diabetes or borderline diabetes. And that prevalence is just as high, actually a little bit higher, 14.2%. So that's in addition to this population with the diagnosis of diabetes, looking closer to 28% of adults who are having some degree of blood sugar management issues. As part of this kind of chronic disease focus piece, I also wanted to share with you some information that we included in the population survey around COVID-19 and specifically vaccination levels. So as I mentioned, this is data that was concluded right near the end of the year. So at the time of the survey, we asked people if they had had any COVID-19 vaccination, at least one shot, if not 2 or 3. And we found that it was about 2/3 of the adult population, 67.4%, who had had vaccination for COVID-19. For those who did not, which is nearly 1/3 of adults in our sample, I've outlined on this slide some of the primary reasons they give for not being vaccinated or not having yet received vaccination. Most related to perceptions of safety or a lack of trust in the vaccine. Nearly as many felt that it was not necessary or for some other reason they didn't want to. Geographically, we saw a little better vaccination levels in the Pendleton area than we saw in Hermiston. There's about an 8 percentage point spread. If you recall back when we shared some of the concerns of the key informants at the very beginning, recall that COVID-19 was really very near the top of their list. One other thing I wanted to share around COVID-19 vaccination was that we asked parents taking part in our survey if they would have their child vaccinated when that vaccination becomes available. And we found that really it was a 50-50 split. 49.1% of adults, higher in the Hermiston area, said that they do not plan or they will not have their child vaccinated for COVID-19. So moving on to the next issue, I want to share a couple of slides around infant health and family planning. And these are information that are collected from the public health data sets, existing data. One relates to infant mortality, which looks at information collected through death certificates. And this represents the deaths of any child or any infant before his or her first birthday. And it's expressed as a rate for every 1,000 live births. By that measure, the infant mortality rate in Umatilla-Morrow County is high in comparison to the US and especially in comparison to the state level. It is also above the Healthy People 2030 target, which is a national disease prevention and health promotion goal, which is to reduce infant mortality to no more than 5 per 1,000 live births. Another piece of information I wanted to share relates to the births to teenagers in the community. And this is information that's collected through birth certificates to mothers who reside in one of the two counties. And it's expressed as a number of births to girls in the age range of 15 to 19 for every 1,000 girls that age in the population. And once again, by that measure, that rate of 32.7 for Umatilla-Morrow counties is really quite high in comparison to what we see at the state and at the national levels. I want to share a few slides with you around mental health. Information that was collected predominantly through our survey of the population. As part of that process, we asked people to evaluate their own mental health. So we asked them in terms of things like anxiety, depression, or problems with emotion, would you say that your mental health is excellent, very good, good, fair, or poor? And by and large, most rated their mental health as excellent or very good. A large segment said it was good in that middle category. But on the lower end of that scale, we had 23%, so approaching 1 out of 4, say that their mental health status is fair or poor. That percentage is significantly above what we have seen nationwide. I will share with you that the US data dates back to kind of the early days of the pandemic, as opposed to this assessment, which was now done recently towards the end of the year. So that is something to keep in mind as we look at some of these data points. In our survey, we also found that about 1 out of 4 adults, 24.9%, report that they themselves have been diagnosed with some type of depressive disorder in the past by a healthcare professional. That too is a little bit higher than we see nationally at about 20%. Not a lot of difference geographically. It's also pretty close in step with what we see for the state of Oregon. Looking beyond just diagnoses of depressions, we had another question in our survey where we asked people if they have had a period of 2 or more years in their lives when they felt sad or depressed on most days. So really talking about a history of periods of prolonged feelings of depression. And by that measure, independent of diagnosed or not, that was true for over 40% of adults in Umatilla and Morrow counties. So 41.6% report having 2 or more years of feelings of depression somewhere in their past, higher than what we see nationally. And demographically, where we see this concentrated is in women, more so than men, younger adults, certainly those at lower incomes, much more likely to have prolonged depression history. Also see it much more prevalent in Hispanic and African American and other communities of color than we see in the non-Hispanic white population. I'll share with you that our survey also found that across the whole population, it's about 1 out of 5 adults who's currently receiving some type of treatment for mental health, whether that be through medication or counseling therapy or some combination. And that 20% is significantly above what we see nationally as well. From some of the public health data, specifically death certificate data, we see that suicide mortality in Umatilla and Morrow counties is high in comparison to what we see across the US. It's similarly high across the state of Oregon. We did have a question in our survey asking about suicide ideation, and we found that 10% of adults in the counties, so 1 out of 10 adults, reports having seriously considered suicide in the past year. And looking back at some of the past assessments for Umatilla County, at least, that appears to have gone up considerably in the past 3 years. A few slides I want to share around this nutrition, physical activity, and weight issue. In our survey, we asked respondents, we asked residents who took part to tell us their height and their weight. And then from that, we calculated a body mass index, or a BMI value, for each respondent. And that's what puts them in a category of being either underweight, healthy weight, overweight, or obese. And by that measure, we found that over 76% of adults in Umatilla and Morrow counties is technically overweight or obese, much higher than we see statewide, much higher than we see nationally. If we look at just residents with a BMI of 30 or higher, which means they are in the obese category, so this second chart is a subset of the first, we find that it's about half of adults who are obese by their height and their weight. And that too is significantly above what we see nationally and statewide. Looking across demographic groups, age, gender, race, ethnicity, income level, we don't really see statistically significant variations. It really is fairly consistent across all groups. And looking back at some past assessments in Umatilla County, suggest that over the course of the last decade, that overweight and obesity prevalence have really increased pretty starkly. Our survey also found that fruit and vegetable consumption in adults is relatively low. We had a series of questions asking people about the foods that they eat. And from that, we determined that 27.4% are getting the recommended 5 or more servings of fruits and vegetables, below what we see nationally. It's even lower in Hermiston area, and also lower in adults in the kind of 40 to 64 age range, as well as those in lower income households. On the side of physical activity, we had a series of questions asking about specific activities people took part in, frequency, duration, intensity. and found that activity levels are relatively low. Currently, 16% of adults in the two-county area meet CDC guidelines for physical activity, which is well below what we see statewide and nationally. And demographically, we see that it is largely related to age, and this is what we see in most communities, but physical activity levels tend to decline pretty sharply with age. There's also a pretty strong correlation with income level, with individuals in those low-income households much less likely to meet CDC guidelines for physical activity. And I know I'm getting close on time, so I'm moving a little bit quickly. I apologize for that. The next few slides I want to share relate to what we call potentially disabling conditions. These are conditions that can contribute or allude to disabilities or activity or other limitations. And in our survey of the population, for example, we found that almost a third of the population reports being limited in some way, in some activity because of a physical, mental, or emotional health issue. And that's a relatively high percent compared to what we see nationally. It's higher in women, adults over the age of 40, higher in lower income populations. And when we ask what it is that limits their activities in Umatilla and Morrow counties, a lot of it relates to kind of musculoskeletal issues, back and neck problems, arthritis, joints, difficulty walking. But mental health was also, as you can see in that list, of some of the top mentioned limitations. Across all the various chronic conditions that we measured in our survey, we found that a relatively high percentage of adults are dealing with 3 or more chronic conditions simultaneously in Umatilla and Morrow counties. That too is higher than we see nationally. And as you might expect, it does increase pretty significantly with age. So older adults are more likely to have diabetes, as we mentioned, but also other conditions like heart disease and stroke, and et cetera. So it's really very age related, but also higher in women overall and higher in lower income populations. On the other side of this coin, I guess, we also found a relatively high percentage of adults in the community who say that they are acting as a caregiver for someone else who has a health problem, long-term illness, or disability. 28.8% are serving that caregiver capacity, higher than what we see nationally. And when we ask the condition of the person they're taking care of, most frequently they mention some type of dementia or cognitive impairment. But mental illness was also frequently mentioned. Cancer also frequently mentioned. Moving on to a couple indicators around substance abuse. If we looked at some of the death rates that serve as measures for substance abuse, for example, cirrhosis and liver disease as kind of a proxy measure for alcohol, knowing that that's not the sole cause, but it is a leading cause for cirrhosis and liver disease. We see mortality rates in Umatilla and Morrow County that are quite high in comparison to the US and to Oregon. We also looked at mortality associated with unintentional drug-related deaths. So these are any unintentional death, so not counting suicide, that involves the ingestion of a drug, whether it be an illegal street drug or a prescription medication on or off label. By that measure, the latest data show unintentional drug-related deaths in Umatilla and Morrow counties is relatively low in comparison to the state and especially to the US. Well, we had other measures that I think we need to take into account here as well. For example, in our survey of the population, we found that a relatively high percentage of adults, 16.6%, have used a prescription opioid in the past year. Whether or not that was prescribed or not, we didn't specify, but we found that 16.6% have used an opioid drug, higher than we see nationally, much higher if we look just at those people who report chronic pain issues. And this is a population that is at perhaps increased risk for addiction. And much of this tracks very closely with what we see in the disability data. It goes up as older adults age, as mobility is limited, et cetera. It is also much higher in non-Hispanic white respondents than we see in our communities of color. Some other findings around substance abuse. We asked several questions around alcohol consumption and behaviors, and we found 18% of adults, for example, are determined to be what we call excessive drinkers. That's actually better than what we see nationally. On the third set of chart bars here, a relatively low percentage of adults acknowledge using an illicit drug in the past month, meaning an illegal street drug or a prescription not prescribed to them. We don't have comparisons for, but we asked about current marijuana or THC use, and that is currently in use by about 17% of adults in the community. And as you can see, 4.7% of all adults said that they have ever sought help for themselves for a substance abuse issue. And then the last piece I want to share is just one final data slide, and that relates to tobacco use. So in our survey, we asked about use of any tobacco product, whether that be cigarettes, smokeless tobacco, chewing tobacco, et cetera. And that prevalence in Umatilla and Morrow counties was 14.3%. A little bit higher, but not significantly different between Hermiston and the Pendleton areas. But we see use much more concentrated in men, as well as in the 40 plus population, adults age 40 to 64 or age 65 plus. In a follow-up question, when we asked people about cessation attempts, we found that it's about half of those who have made some attempt to quit tobacco use in the past year. And I just want to mention here, recall that tobacco was one of those top 5 concerns expressed by the key informants in that very first slide that I shared. So with that, I know I've probably taken up all my time, but I do want to give you an opportunity to ask any questions that you have. As part of this assessment process, we sought input from those key informants to establish some priorities around the health issues that we identified. So I want to put up on screen kind of the emerging prioritization list that resulted that came out of that community health needs assessment process. So I'll leave that up on screen actually while I field any questions you have.
Yeah, thanks. This is Brian. I've got like a multiple part question for you. And I'm glad you put this up because this was actually part of it. How do we prioritize the results as we get into our implementation plan development and align that with our strategic goals of the organization? So my first question really is, and this is probably the primary question, is how many folks did you send the survey out to? What was the response rate? And how is it, how can you tell if it's statistically valid? And the reason why I'm asking that question, and I don't have a better example than what I'm going to throw at you, and this is kind of a stretch, but you had one of your slides talk about obesity. People reported how tall they were, what they weighed, and so there was just this assumption that they're obese, although there may be some of those folks out there that, I said this is a stretch, could be, like into bodybuilding, that kind of stuff, and they may have like that body fat. So how do you validate these statistical results for that?
Yeah, So that's good questions, two very different questions. So let me talk about the first one first. So in the sampling, we had a couple different approaches. The bulk of the surveys were achieved through a random sample phone-based survey. And that's where we randomly select households from a universe of all known phone numbers in the 2-county area. And that random selection process is what is key to yielding that statistically meaningful sample. We did also have some outreach components through online surveys. So Good Shepherd and CHI St. Anthony promoted the link in the communities to get people to take the survey online. That is much more of a convenience sample. So what we did was we folded those into the random sample using some weighting practices to mode adjust. And if you go back to that one slide I shared at the beginning that looks at the population, how the population compares to our survey sample, that is really the most telling piece of this, is that the survey looks like the population in terms of its makeup and is representative in those terms. And that's what really allows you to project these findings to the larger population. Now, Brian, to your question about like the BMI measures, that is a good point. And I will be the first to admit that BMI is maybe not the most precise and consistent measure on an individual level, but it's proved to be very stable and very meaningful, particularly at a population level. So assuming that you're not a population of bodybuilders, it can vary for any individual throughout the community, but in looking at the aggregate, it tends to be a very stable and very good predictor of health, of overweight and obese prevalence.
Yeah, I said it was a stretch.
No, it's a good question because for any one individual, it can be more or less meaningful.
And that's when it gets down to the statistical validity of the survey itself.
Yeah, absolutely. And these, this in terms of the survey tool, these are questions that are, barring a few questions that were carried forward from previous assessments or custom created to get it information we needed, the bulk of these questions are things that are largely validated through the CDC survey that's been going on for 40 plus years, or through the PRC surveys that we've been using for close to 25 years. So many of the questions have been validated through that mechanism as well.
So I have a couple questions. This is Steve Eldridge, board member. I personally don't find the fact that the survey that was sent out matches up with the various populations for this reason, unless there's more to your answer. You could meet those percentages of different groups as long as they're randomized for each community, because each community is significantly different. Umatilla and
Right.
Ford are significantly different, and I just don't think that I'm concerned about the projection being as accurate as we would like. That's one thing. The second thing is, I'm wondering, when we compare the efforts in Umatilla-Morrow County with the state results and the federal results, I'm not sure they're really comparable. The timeframes are different. We don't know what the methodology is. Census data is completely different than a randomized sample.
Right.
So that's a little bothersome. And then finally, in our state particularly, they're pushing on health equity, which has to do with basically the non-white population. And I'm not a huge supporter of that concept, but it seems to me that we have to have more information about the micro populations, Black, Asian, Native American, uh, Latino, is almost equal in number to the white population in Umatilla and Morrow County. And it's hard for me to really think about them in a true minority sense, even though I do believe that they're kind of at the beginning of the economic road upward. And the other group that's growing that we know very little about, but is for lack of a better term, a frequent flyer at the ER, is the homeless population. And in speaking to people that work in that area, they believe pretty strongly that the substance abuse question many times is masked and interpreted as mental health when the root is really substance abuse. And so I don't know what to do with this data and how to change our strategic plan if necessary, that we can demonstrate that it really is in line with the community needs. Thank you.
Yeah. So Steve, you packed a lot of questions in there for me. So let me kind of go through.
First, let me just throw something in there real quick, because
Okay,
for my
sure.
own clarification to piggyback on Steve, in the results that you're presenting to us today, is that just our zip codes within our primary service area? It's not all of Umatilla County, right?
The data that I shared today does show, well, it shows both. So it is, hopefully you can see on screen. So kind of the top line findings are the full collection of Umatilla and Morrow counties. Then there's breakouts within that for the Hermiston zip codes and the Pendleton zip codes separately. In that full CHNA report, that's available across the board, across all indicators. So does that answer your question, Brian?
It does. Thank you.
Okay, so Steve, let me get back to kind of your questions. I think the first one was about sampling, and you're right. It's not that we match the demographics and therefore it's good. It's that we did randomly select respondents. That's what brought us to a sample that was representative, and that is why we can project. So the surveys were administered randomly within the Hermiston zip codes and the Pendleton zip codes among all. So every household in the population had an equal chance to be selected. So it's that random selection that makes it so that this chart on here looks very much like the population. I think that was kind of the crux of your first question, if I'm not mistaken. The second point about benchmarking is those are good points. That the primary difference to keep in mind is that they are administered at different times, and certainly this past year and a half, 2 years, has been like no other. So that can be a contributor. All of the benchmarks that we share in our report are methodologically similar. So it's not really a factor of the methodologies being different, but certainly that time frame can be a contributor to differences that you see, and we do need to take those into account, like I mentioned with mental health, for example. And then I think Steve, your last piece was around the equity piece. And there is opportunity beyond the information that I shared today, and even beyond what's in the static reporting, to drill down into different segments of the population, whether that be by race or by different configurations of age or even zip codes, to look at disparities in different ways. Now, some of the populations that are very, very small across the 2-county area relative to the whole, there may or may not be samples large enough to isolate them specifically without, starting to maybe do some grouping. But there is, with the population survey data at least, the ability to look at much more granular levels than I was able to share today. So I think those are your three main points, if I'm not mistaken.
Thank you.
Yep, absolutely.
What other questions do others have? Okay. Well, I don't see any other questions. Bruce, I would like to thank you and your staff for doing this presentation for our trustees.
Absolutely.
I know that there is going to be another virtual presentation on February 2nd, I believe it is.
I believe that is correct. Jessica,
So,
that's the date.
Yeah. Sorry, Brian. Yes, Bruce will be presenting again to community members Wednesday, February 2nd at 1 p.m. That will kind of delve even deeper into this data. And everyone on this call will be invited to that presentation as well. And that will include a prioritization exercise, which will be the beginning of our chip creation.
And it'll be recorded too, right, Jessica?
Yes,
Correct.
it will. That community presentation will be recorded and shared with the public as well. Mm-hmm.
Outstanding. Very good. Okay. Well, I would say if there's no other questions or comments, I'd like to thank you all for attending today. Very informative. And I look forward to see how the implementation plan comes together and get that one done.
Absolutely. And from PRC, I want to thank you all as well.
Have a great day.
All right. Thanks, everyone.
Thank you, everyone.